This conference will now be recorded.
Right, so today we're going to talk about approach to a patient with thrombocytopenia. This class was discussed with you guys in your 4th semester, if I'm not wrong. So we'll just go ahead with this. I hope you can see the slides and my voice is clear. So introduction. Thrombocytopenia is defined as decrease in the number of platelets in peripheral blood below 1.5 lakh per cubic millimeter. So less than 1.5 is supposed to be thrombocytopenia. Platelets with a count of 20,000 to 50,000 per cubic millimeter aggravate post-traumatic bleed. So if the patient has trauma and if the platelets are less than 50,000 or between 20,000 and 50,000, then there can be some amount of bleeding. And platelets less than 20,000 have spontaneous bleeding. And that's the problem with less than 20,000. You have to intervene immediately because they can have spontaneous bleeding. They need not have any sort of trauma for this. And spontaneous bleeding due to thrombocytopenia mostly involves the small vessels. Luckily for us, it's not the large vessels. So if the large vessels are involved, there'll be massive bleeding and immediate death. So only the small vessels which have small capillary walls, they will get affected with platelet count less than 20,000. The common sites are skin and mucous membrane of gastrointestinal and genitourinary tract. So that is why most of the symptoms are related to these things. So there'll be epistaxis or there'll be hematemesis or melena, and then there can be hematuria and hematochezia and all these things. So that is why these are the most common sites and the most common symptoms are related to these particular sites. So coming to the next slide. So the causes of thrombocytopenia are decreased production. The next slide, increased destruction, other causes, and pseudothrombocytopenia. So first one is decreased production. So there has to be a decreased production, there has to be an increased destruction, or there has to be another cause which will again lead to thrombocytopenia. So first one is decreased production. This is the more common cause in terms of younger age groups. So marrow suppression, first one is marrow suppression. It's common, it's usually pancytopenic, it's post-viral, parvovirus, hepatitis B or C virus, Epstein-Barr virus, varicella, measles, mumps, rubella, MMR vaccine itself, CMV, cytomegalovirus, toxoplasmosis influenza. And now even COVID-19 is added to this particular list, the cause of thrombocytopenia. Although it's not so evident in COVID-19, it can be seen. Then you have sepsis, aplastic anemia, direct megakaryocyte damage in case of HIV, direct toxicity to bone marrow like radiotherapy, chemotherapy, excess doses of alcohol, marrow infiltration, lymphoma, myelofibrosis, metastasis, and TB. Lymphoma and myelofibrosis we discussed in previous classes. We can have thrombocytopenia in those cases. There can be metastasis and also tuberculosis. Tuberculosis of the bone marrow. These can cause thrombocytopenia, decreased production. Continuing, there will be drugs with toxic effect which are non-immune mediated. Immune mediated will cause destruction. So non-immune mediated will cause decreased production. Thiazides like estrogens, chemotherapy, cimetidine, famotidine, these can cause decreased production. Myelodysplastic syndrome, age greater than 60, usually anemic and leukopenic, they can cause that. Leukemia, myeloma can cause. B12 or folate deficiency can cause, well, although it's rare, but it'll also be seen. Congenital like Viscoat-Alvich syndrome, Fanconi syndrome, Bernard-Soler syndrome. These syndromes, you just need to remember the names of these syndromes. Viscoat-Alvich, Fanconi, and Bernard-Soler. These can also cause decreased production of platelets. Next one is immune destruction, which is causes. So immune mediated and non-immune mediated. Immune mediated is ITP, idiopathic thrombocytopenic purpura, or immune thrombocytopenic purpura, drug-induced, and rheumatic diseases like SLE, rheumatoid arthritis, Aplas syndrome, HIV. 40% of the patients will have immune mediated. Post-transfusion can be there. Post-transplantation can be there. In non-immune mediated, it's TTP, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome (HUS). The suspect when the low platelets and MAHA, microangiopathic hemolytic anemia. And then DIC, it's disseminated intravascular coagulation, preeclampsia, HELP syndrome, which is seen in case of pregnancy, then toxic shock syndrome and vasculitis. So these are all the increased destruction causes of platelets, thrombocytopenia. Other causes are dilutional thrombocytopenia, where stored whole blood is deficient in viable platelets and labile coagulation factors of 5 and 8. So transfusion of massive amounts of such blood to individuals with severe blood loss can lead to thrombocytopenia or coagulation factor deficiency by dilutional effect. Bleeding due to this can be prevented by transfusion of FFP and platelet concentrates along with the stored blood. So when you're transfusing whole blood, you have to make sure that the patient is going to have enough coagulation factors and enough platelets through FFP and platelets transfusion. So this is dilutional thrombocytopenia. The next one is increased sequestrations. It's equal to increased destruction, but sequestration is not a pathological process, it's a physiological process, but it's just increased. So normally 30% of total platelets in body are sequestrated in the spleen. In conditions associated with enlargement of spleen, splenic platelet pool expands and may reach up to 90% in some cases. So this increased sequestration can be seen in chronic liver disease, it can be seen in malaria, it can be seen in conditions like CML, it can be seen in a lot of conditions that cause increased splenic size. So hypersplenism can cause this sort of destruction of platelets and cause thrombocytopenia. So up to 90% in some cases. The next entity is pseudothrombocytopenia. So in evaluating a patient with thrombocytopenia, a key step is to review the peripheral blood smear to rule out pseudothrombocytopenia. So what is pseudothrombocytopenia? It's a false thrombocytopenia on usage of EDTA, a collection of blood sample. So EDTA will cause false thrombocytopenia and it can cause clumping of the platelet. So it should be, blood smear should be evaluated and platelet count should be determined and blood collected into heparinized or sodium citrate tube, not EDTA. So this is pseudothrombocytopenia. You can see these are clumps of platelets. So when you go through a machine count, the machine counts them as 1, 2, 3, 4, 5, 6. But actually there might be a lot more in this. So once you magnify and see, you can see that these platelets are clumped together. This is pseudothrombocytopenia. So how do you approach a case of thrombocytopenia? Today's class is how do you approach, how do you diagnose, how do you, what are the other conditions that can cause this? So first one is history. You obviously have to take medication history, including the herbal medications, and over this herbal medications can cause thrombocytopenia. They can cause renal failure. So using herbal medications, especially which are high doses, you have to be very careful. You have to be very careful in asking the history of herbal medications because they can cause renal failure also. So in turn, renal failure again can cause thrombocytopenia. So it's all interlinked. So alcohol, nutrition, travel history, HIV risk factors, bleeding history like bleeding gums, menses, and surgical complications, and then family history. So these are all important history. Important in family history, especially important in case of suspicion of congenital or young people presenting with thrombocytopenia. Next is physical examination. You have to examine the spleen, detailed skin examination. You have to look for petechiae, which are red pinheads. You already know what is petechiae, purpura, purple confluent petechiae, and then ecchymosis, large areas of bleeding over the skin that are seen. You have to look for lymphadenopathy to look for leukemia or lymphoma or any other tuberculosis or whatnot. Then signs of chronic liver disease, which will also show that there is a splenomegaly. Sorry, 1 second. Yeah, so they also show that there are splenomegaly. So you have to look for signs of CLD. You have to look for splenomegaly. You have to do abdominal examination and then you have to do abdominal examination and then you have to look for any signs of hepatomegaly, any signs of splenomegaly. If spleen is present, then you have to look for what is the size of the spleen, has it crossed the umbilicus, and all that. One second. So that's a good approach. So this is a picture of petechiae. You can see small, confluent, raised pinhead type hemorrhages on the skin that are seen. So the next thing that you do is you have to get a peripheral smear. So in the peripheral smear, you have to look for large platelets. So high MPV on CBC, it implies increased destruction. So early release from the bone marrow, probably seen in ITP. Now ITP is not diagnosed just based on this particular thing. It's a diagnosis of exclusion. So you have to go for all the other tests also to rule out the other causes. So increased destruction and all you have to rule out. So normal small platelets suggest reduced bone marrow response. Cystocytes or fragmented RBCs suggest microangiopathic hemolytic anemia. And even the peripheral smear can reveal blasts, so you have to have a suspicion of leukemia there. Teardrop RBC, nucleated RBC can suggest bone marrow invasion, so tumor, fibrosis, granuloma. These nucleated RBCs and teardrop RBCs are immature RBCs that are released from bone marrow before maturation. So why are they released from the bone marrow? Because the bone marrow has cells in it which will take up the space. So either fibrosis or granuloma or tumor in the bone marrow will propel the RBCs which are immature to come outside into the peripheral blood. So that is why teardrop RBC, nuclear RBC can be seen. Then macrocytosis with hypersegmented neutrophils can suggest vitamin D or folate deficiency. So these are the approaches when you look for certain things in peripheral smear. So peripheral smear is very important. Now you all have studied about peripheral smears. You have in previous classes I also studied pathology, so I'm not going to go in detail. But yeah, so the next step is to get investigation. So first is PT APTT. PT and APTT, it's high in microangiopathic hemolytic anemia and disseminated intravascular coagulation, and also in liver disease. So PT and APTT is elevated in acute liver disease. In chronic liver disease, albumin is decreased, right? So LDH is seen in hemolysis, microangiopathic hemolytic anemia, increased LDH. Increased LDH is also seen in COVID now, guys. And then blood urea nitrogen or creatinine, it's increased in hemolytic uremic syndrome or thrombotic thrombocytopenic purpura, where there will be kidney involvement. And then consider toxoplasmosis, EBV or CMV serologies if lymphadenopathy is there or splenomegaly is there. EBV and CMV especially will have lymphadenopathy. Generalized lymphadenopathy is most commonly seen with EBV or infectious mononucleosis caused by EBV. Then you have to consider HIV if there is initial disease manifestation is only 10%. And then consider ANA if there is any clinical suspicion of any autoimmune disease, any rheumatic disease. If you suspect SLE, you have to go for ANA, it's a screening test. If ANA is positive, then you have to go for double-stranded DNA, anti-dsDNA antibodies. If ANA is positive, then you can go for rheumatoid arthritis if there is any small joint involvement or any joint deformities. If there is any skin tightening, you can go for systemic sclerosis. If there is any excess thrombosis or any DVT, or you can see splenic vein thrombosis or hepatic vein thrombosis or Budd-Chiari syndrome, you have to go for suspicion of APLA, anti-phospholipid antibody syndrome, and you have to get anti-cardiolipin antibodies and all that, right? So that is about the approach. So the last step, or probably I won't call it the last step, but the definitive step is bone marrow biopsy. It more definitely answers the production versus destruction question. If there is increased number of cells in the bone marrow, that means there is destruction going on, because the bone marrow response is parallel to the amount of destruction that's happening in the peripheral blood. So more blood destruction, more stimulus to the bone marrow, and there will be more production. More production in the bone marrow. So there will be more cells in the bone marrow. If the production is affected in the bone marrow itself or bone marrow failure, the cells in the bone marrow will be less, or the cells will be replaced by something. So it's generally indicated in unexplained thrombocytopenia if platelet count is low enough to be at risk of major bleeding. Unless the age is less than 60, thrombocytopenia is isolated, and history or physical examination space as the diagnosis of exclusion of ITP. So if ITP is suggestible, then you need not go for bone marrow. If age greater than 60 and suspect likely ITP, bone marrow biopsy are generally indicated for myelodysplasia. So greater than 60, because myelodysplastic syndrome is a disease of the older age group, you have to go for bone marrow biopsy to form a definitive diagnosis of myelodysplasia. If it's not there, then you can consider ITP. But ITP is usually suspected in younger age group, usually around 20 to 30 years of age. So the common causes again, first one is infection-induced thrombocytopenia. Is the most common non-iatrogenic cause of thrombocytopenia. So obviously drug-induced thrombocytopenia is the most common cause, but the non-iatrogenic cause is infection-induced thrombocytopenia. They can affect both platelet production and survival. Immune-mediated thrombocytopenia also occurs in children following viral infection, which resolves spontaneously. So in children following viral infection, it resolves spontaneously. There are usually not many symptoms. You can have some amount of fatigue. In HIV, the most common cause is immune thrombocytopenia, which may be associated with hepatitis C co-infection and produces decreased platelet survival, particularly at CD4 less than 200 microliter. So we have a question where they'll ask which hepatitis infection can exacerbate the thrombocytopenia that is seen in HIV. It is hepatitis C. Hepatitis C co-infection. It produces decreased platelet survival, so particularly of CD4 less than 200. If the CD4 count is less than 200, then there might be immune thrombocytopenia. In malaria, thrombocytopenia is probably due to immune-mediated lysis, sequestration of the spleen, and diminished platelet production. In addition, lifespan of platelets is decreased to less than 4 days. So you know the pathophysiology of this in malaria. You've already studied that. So the next one is drug-induced thrombocytopenia. Due to drug-dependent antibodies that react with specific platelet surface antigens result in thrombocytopenia, and only when the drug is present. It is more common with quinines and sulfonamides. Quinines, again antimalarial drug, primaquine, quinine, chloroquine, and then sulfonamides. It typically occurs after a period of initial exposure or upon re-exposure, and usually results in 7 to 10 days after drug withdrawal. 7 to 10 days after the drug withdrawal. Abciximab. In this, thrombocytopenia usually occurs within 24 hours of initial exposure. It is due to the presence of naturally occurring antibodies that cross-react with the drug-bound platelets. So, if someone presents to you with thrombocytopenia after in less than 24 hours after taking abciximab, then you have to. If the patient has a drug history of treatment of anti-platelet drug, and he presents with thrombocytopenia within 24 hours of taking drug, then you have to suspect abciximab. And if it is abciximab, that is probably because of this initial exposure because of naturally occurring antibodies. So that was about abciximab causing drug-induced thrombocytopenia. So what are the other drugs that can cause thrombocytopenia? So heparin, which is commonly used again, valproic acid or carbamazepine, anti-seizure drugs. Gold salts can cause, quinine or quinine can be causing, it's an antimalarial drug, sulfonamides, penicillin, beta-lactams can cause, interferons can cause, abciximab, which is a GB2B3A inhibitor, and amiodarone, amphotericin B, vancomycin, cimetidine, phenytoin, clopidogrel can cause digoxin, fluconazole, and ranitidine. These are all the drugs that can cause thrombocytopenia. These are all the drugs that have thrombocytopenia as their side effect. So I'll go to the next slide. So what is HIT? It's not high intensity interval training. It is heparin-induced thrombocytopenia. So it differs from drugs in the thrombocytopenia is usually not severe. It's rarely less than 20,000. Heparin-induced thrombocytopenia is not associated with bleeding. In fact, it markedly increases the risk of thrombosis because of utilization of all the fibrinolytic factors. So it is not associated with bleeding. It markedly increases the risk of thrombosis. So heparin-induced thrombocytopenia, unlike the other thrombocytopenias, will not cause bleeding. It will increase the risk of thrombosis. It's the opposite, right? So remember that, please. What is the mechanism? It results from antibody formation to a complex of platelet-specific protein, platelet factor 4, and heparin. So anti-heparin or platelet factor 4 antibody can activate platelets through Fc gamma R2A receptor, also activates monocytes and endothelial cells. So when these are activated, there can be increased chance of thrombosis. That's the mechanism. Just need to know that there's an anti-heparin platelet factor 4 antibody. Many patients exposed to heparin develop antibodies but do not appear to have adverse consequences. A fraction of these develop HIT, and a portion of which develop thrombosis will have HIT thrombosis. So it's because of heparin developed antibodies but do not appear to have adverse consequences. So heparin can cause heparin-induced thrombocytopenia in some patients, but they will not have bleeding, and sometimes they can have thrombosis. HIT can develop after exposure to unfractionated heparin more than low molecular heparin, usually after 5 to 14 days after exposure. So it occurs before 5 days in those who are exposed to heparin in the prior few weeks or months and have circulating antibodies. Rarely, thrombocytopenia and thrombosis begin several days after the heparin has been stopped. So delayed onset HIT can also be seen. So laboratory diagnosis is two types of assays. One is ELISA, it's most widely available. You have to get PF4 antibody or polyanion complex antigen, low specificity. IgG specific ELISA increase specificity but decrease the sensitivity. So that is for diagnosis. It's not usually necessary. When there is a history of heparin, you have to suspect HIT. Platelet activation assay, most commonly serotonin activation assay, which measures the diality of the platelet serum to activate platelets in presence of heparin in concentration dependent manner. It is less sensitive and highly specific than ELISA. It's more specific, so it's not used as a screening test. Only you have a suspicion, you can confirm it with platelet activation assay. So what is the treatment? Treatment is the most important thing here because you need to know what to do next. Stop heparin. First, stop heparin, obviously. Use of alternative anticoagulant if bleeding risk outweighs the thrombotic risk. So if the thrombotic risk is more, if the bleeding risk is less, and then you have to go for alternative anticoagulant. If the bleeding risk is more, then you cannot give anticoagulant. Thrombosis is common complication even after discontinuation, can occur in both arterial and venous systems, more common in the venous system. Evaluation of patient with lower extremity Doppler imaging is recommended to look for DVT. Other anticoagulants like direct thrombin inhibitors like argobatrin and epidurin are effective. Bivalidin and antithrombin binding pentasaccharide fondaparinux is dose effective but not effective, not approved. So fondaparinux can be used but not approved. Argobatrin and epidurin can be used. Other ones like dabigatran can also be used. Danaparanoid as an anti-10A inhibitor can also be used. In platelets with thrombosis, anticoagulant therapy is usually for 3 to 6 months. In patients without thrombosis, duration of anticoagulant needed is undefined. So it's probably for a week or so. Once the patient is normal, you need not give. So in patients with thrombosis, you have to give for 3 to 6 months. So the other important one is immune thrombocytopenic purpura, also termed as idiopathic thrombocytopenic purpura because we do not know the exact cause of it. It's an acquired disorder, it's not congenital, in which there is immune-mediated premature destruction of peripheral platelets and possibly inhibition of platelets released from the megakaryocytes. So decreased production and also increased destruction can be seen. It's an immune-mediated process. It occurs in two forms. Acute IDP is a short illness of sudden onset, occurs in children 2 to 6 years following viral infection. Vaccination after an interval of 2 to 3 weeks. Immune complex of viral antigen and post-antiviral antibodies bind to FC receptors and platelets and lead to destruction of macrophages in spleen. So this can be seen in children. It's a short illness of sudden onset. It's usually self-limiting. Chronic ITP is an indolent disorder of insidious onset with multiple remissions, relapses predominantly in young women. Okay, young women, not preceded by infection or associated with platelet antigen. In this, autoantibodies are mainly IgG and less commonly IgM, which are directed against specific platelet glycoproteins. This one, GP2B3A and GP1B1X in majority of the patients. These are sites of fibrinogen binding during platelet aggregation. So apixaban and tirofiban, etc., they can be used in these conditions. They should not be given in chronic ITP. They are antiplatelet agents which are used to suppress these receptors. So in addition to causing platelet destruction by macrophages, these antibodies also induce platelet dysfunction by blocking GP2B or 3A receptors. So you cannot give antiplatelet drugs here because these will be blocking these receptors also. So chronic ITP presents with thrombocytopenia, also decreased function of the platelet because of blockage of GP2B through a 3A receptors. Right? Next, we have clinical features. The incidence of ITP increases with age, but it's more common in the young women. Presentation varies with severe thrombocytopenia and bleeding, and it's from asymptomatic mild thrombocytopenia detected incidentally. So there'll be usually asymptomatic mild thrombocytopenia. Sometimes it can have severe thrombocytopenia and bleeding. So what do we do next? First one is acute ITP. What do we do? Disease starts suddenly with cutaneous and mucous membrane bleeding in form of purpuric spots and ecchymosis, bleeding from gums, nose, and there'll be hematuria. Intracranial bleeding can be fatal. Presence of web purpura and retinal hemorrhages may herald life-threatening bleeding. Spontaneous remission usually occurs within 2 to 6 weeks in more than 80% of the patients. So 2 to 6 weeks, spontaneous remission can be seen in more than 80% of the patients. In 15 to 20% of the patients, it persists beyond 6 months. So that is an acute ITP. Next one is chronic ITP. It presents as insidious onset of superficial bleeding from skin and mucous membranes. Menorrhagia is common in women. Chronic bleeding will have iron deficiency anemia because of blood loss. Presence of splenomegaly is an alternative diagnosis to be considered. So splenomegaly, you have to go for bone marrow in these patients. In the patient with suspected immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura, if there is splenomegaly, you have to go for bone marrow biopsy. If the bone marrow biopsy is normal, you can start treating the patient for ITP. Some patients may have thrombocytopenia detected incidentally. In primary ITP, isolated thrombocytopenia without any underlying cause. In secondary ITP, it's with underlying cause like dengue SLE infections. Lab diagnosis of ITPs by exclusion. You have to go through all the tests. Peripheral smears places are large in size sometimes. Acute ITP platelets less than 20,000. Chronic ITP around 50,000. Bleeding leads to iron deficiency anemia. Picture in the peripheral smear. Bone marrow examination. Bone marrow examination. Megakaryocytes are normal or increased in size. If clinical features CBC smear indicate ITP, bone marrow examination is not necessary for diagnosis. However, it should be carried out if presentation is unusual with presence of hypersplenomegaly and morphological abnormalities in WBC or age greater than 60 years to rule out myelodysplastic syndrome. Antiplatelet antibody panel is not generally recommended because it's low sensitivity and specificity. So this is about the investigations or lab diagnosis of ITP. So what do we do to evaluate for secondary cause of ITP? Test for HIV and HCV infection, serological testing for SLE, selective testing for IgA deficiency, and test for H. pylori infection should be carried out depending on the clinical circumstances. If anemia is present, direct anti-globulin testing should be performed to rule out combined AIHA with ITP, with Evans syndrome, right? Autoimmune hemolytic anemia with immune thrombocytopenic purpura, that's seen in Evans syndrome. So what is the treatment? It uses drugs that decrease reticuloendothelial uptake of antibody bound platelets, decreased antibody production, and increased platelet production. So the diagnosis of ITP does not mean treatment must be instituted. Patients with platelets greater than 30,000, they don't have increased mortality or morbidity. So anyone who's less than 30,000, they're going to have these symptoms. So again, I'll just go. The uses drugs that decrease reticuloendothelial uptake of antibody bound platelets, decrease antibody production, and increase platelet production. So it does not mean treatment must be instituted. Only with symptoms and the ones that have less than 50,000, you can go with treatment. The platelets with greater than 30,000, they don't have increased morbidity. So first one is initial treatment of patient without significant bleeding, severe thrombocytopenia, signs of impending bleeding, can treat as outpatient using single agents. So the most common one is prednisolone. It's a steroid that can be used for immunosuppression. 1 mg per kg. So if a patient is weighing around 60 kg, you start with 60 mg. And also D is immunoglobulin therapy. A row immunoglobulin therapy at 50 to 60, 75 UG per kg is being used. RH immunoglobulins must be used only in RH positive patients because mechanism of action is production of limited hemolysis with antibody coated cell saturating the Fc receptor, inhibiting its function. So if you give an RH negative patient, they're going to have hemolysis. That is why it can only be given the RH positive. But the most common treatment is prednisolone. It's being used quite frequently now. Monitoring the patient for 8 hours after infusion is now advised by the FDA because of rare complication of severe intravascular hemolysis. Intravenous IgG also blocks the Fc receptor system, but through different mechanisms. It has more efficiency than anti-D in post-penitomized patients. So in post-penitomized patients, intravenous IgG should be given. And monitoring the patient for 8 hours of the transfusion is also advised by the FDA because of the rare complication of severe intravascular hemolysis in case of immunoglobulin therapy. The dose is 1 to 2 kg given over 1 to 5 days. This one, anti-D or intravenous IgG. The side effects depend on the volume of infusion and frequently induces aseptic meningitis and renal failure. These are the drastic complications of this particular therapy. All immunoglobulin preparation are derived from human plasma or undergo treatment for viral inactivation to make sure that there are no viruses that you're transmitting through this immunoglobulin therapy. So for patients with severe ITP or symptoms of bleeding, you have to go for hospital administration and combined modality therapy is given. High dose glucocorticoids with IVIG anti-D therapy should be given. Additionally, immunosuppressive agents when required. So the additional immunosuppressive agents are rituximab. Rituximab anti-CD20 antibody. It's effective in refractory ITP, although long-lasting remission only occurs in 30% of the patients. But it can be given. Splenectomy has been used for treatment of patients who relapse after glucocorticoids are tapered. Vaccination against encapsulated organisms like pneumococcus, meningococcus, Haemophilus influenzae is recommended before splenectomy. So encapsulated organisms you have to give before splenectomy because these are the most common infections after splenectomy. Thrombopoietin receptor agonists are now available for treatment. Romiplastone is a subcutaneous delivery. L-Thrombovag, it's oral, effective in raising the platelet count in ITP and recommended for adults at increased risk of bleeding who relapse after splenectomy, who are responsive to at least one therapy, who have contraindications to splenectomy. You can give thrombopoietin receptor agonists. Short-term treatment with T2 agonists can be considered after splenectomy. Sorry, before splenectomy. So before doing splenectomy, you can consider this drug also. So next we have thrombotic, thrombocytopenic microangiopathies. I think we can discuss this in the next class because it's got a little more. It might take around 20 minutes or more. So yeah, I think we can switch this in the next class. So yeah, today's class was about thrombocytopenia. Just going back. Sorry, that was. So you have again causes are decreased production, then increased destruction. The other causes of dilution thrombocytopenia, increased sequestration, pseudothrombocytopenia. Then there's approach, you know what to ask, and the physical examination that needs to be done. And then when peripheral smear, there's certain aspects that you need to look for. And then there's bone marrow biopsy, which is a definitive diagnosis to rule out myelodysplastic syndrome. Then the most common cause is drug-induced thrombocytopenia. The second one is infection-induced thrombocytopenia. And drug-induced, these are the common drugs that can cause. HIT is not high intensity, it's heparin-induced thrombocytopenia. The mechanism, the clinical features, laboratory diagnosis, and treatment to stop heparin, use argabatron. It's a direct thrombin inhibitor. You can give fondaparinux, but it's not effective. Danaparanoid can be used. Then ITP, immune thrombocytopenic purpura, where you have acute ITP, chronic ITP, and clinical features, usually not much. Acute ITP will have certain bleeding manifestations. Chronic ITP less likely, but they can have splenomegaly. With this splenomegaly, you have to go for bone marrow biopsy. Then lab diagnosis, you go for bone marrow examination, and then other tests for secondary ITP, HIV, HCV, SLE, and then Evans syndrome. Treatment is only if the patient has symptoms. You can go with prednisolone or immunoglobulin therapy. Intravenous IgG can be given. It's more efficient than anti-Ro antibody in post-penitomized patients. Doses 1 to 2 gram per kg over 1 to 5 days. High dose glucocorticoids in case of severe bleeding, along with intravenous immunoglobulin therapy. Rituximab can be given, splenectomy can be done, vaccination should be given before splenectomy. And thrombopoietin receptor agonists like rombiplastone and eltrotumab can be used in cases of refractory cases and splenectomy. So this we'll discuss in the next class. So that is about today's class. If there's any doubts, you can ask me. If there's no doubts, we can end the class.
Sir, rationale of using bone marrow biopsy in ITPs. Can you repeat that once?
Sorry, bone marrow biopsy
In ITP, sir.
What is the rationale? So there's no rationale. If you suspect ITP, you need not do bone marrow biopsy. But if there's associated hepatosplenomegaly, if there's associated abnormal cells in the peripheral smear, so there might be blast cells which have an abnormal morphology, either immature cells or increased number of blasts in the peripheral smear, then you have to go for bone marrow biopsy because you have to rule out bone marrow infiltrative disorders. So infiltration is any fibrosis or any tumor cells. So only by doing bone marrow biopsy you can come to a definitive diagnosis that there is no myelofibrosis, which was again infiltration of the bone marrow, that there is no leukemia or lymphoma with infiltration of the bone marrow. So in these cases you have to do bone marrow biopsy, especially this hepatosplenomegaly, because these disorders will more commonly present with hepatosplenomegaly. So in ITP, it's not necessary. It's a diagnosis of exclusion, but you have to exclude by first by history and physical examination, then by peripheral smear. If nothing is suggestive of any other cause, it's a diagnosis of exclusion. So you can label the patient as ITP. So if you start the patient with steroids and there's response to steroids, it actually confirms your diagnosis. So you need not do bone marrow biopsy in every patient with ITP. Only in those with hepatosplenomegaly, abnormal cells on the peripheral smear, and in age greater than 60 years, you have to go for this. Is that clear?
Thank you, sir. Clear.
Okay. Any more doubts? Right. So if there's no more doubts, we can end the class. Thank you.